there waiting for her ride, and there's a news crew talking about what occurred that day shortly within a short distance. And we tried to advise them and warn them. Ms. Menashe, I don't want to use the term yell, but spoke, clearly tried to get their attention, and she was being ignored. And I just think that an adjustment has to be made as to that live shot or that location.
Well,
it was inside the courthouse, not outside the courthouse grounds.
my suggestion to them is going to be they can either go down by a probation intake, which takes them totally out of the area, or they can go further east and be there in the corner. That might be a light issue for them. So down the hall is probably a more appropriate place to go. But I have not had a chance to talk. I don't know who was on last night, if it was Bennett or somebody else. But we're going to suggest to them that if you're going to do something in the courtroom, take it down the hall, take it to another courtroom. We can open up, if they want to do their live things in the courtroom next door. I don't have a problem with that. We'll find some other accommodation. But I don't want my jurors uncomfortable. Okay? Anything on this from the state? Since you guys are probably just finding out about all this. Okay? The second thing is, it's my understanding Ms. Sawyer tested negative. I got a text last night. Is she coming in today, or?
No, Judge. Saturday she took a test, and she took a test last night again, and she's negative again. She has a sinus infection, so she's just going to stay home. We anticipate Dr. Schreiber being on the stand the whole day. She's going to try to get to her doctor to get some antibiotics today. Hopefully be on the mend when she comes back in tomorrow.
Okay. We had put that on the record yesterday. I just wanted to make sure that we got it covered. Ms. Grubb, is there anything else for the record before I bring the jury in?
I think so, Your Honor.
Ms. Menashe?
No, yeah.
Okay, let's bring him. We do have a guest bailiff today.
Those are going to be in there at the end of the test. Yes. There you go.
How you doing, Max? How's those beautiful kids of yours?
Outstanding, girl.
The oldest has got to be, what, 5? No? Just two?
My wife gets this new job, maybe all about 2 doors.
Huh? It's as a plexiglass. It's okay. I never saw anybody as happy as he was when he found out he was going to become a dad. He was just glowing when he came into court that day.
Life's worth living now.
Yeah.
All rise.
I can do it. You can be seated. Good morning, ladies and gentlemen of the jury. Hope you have a wonderful evening. We're going to continue on with testimony. We'll let him get set up with his medicinal situation. Go ahead. We want you to be comfortable as you can. Okay, we're going to continue on the testimony. Doctor, you're still under oath.
Yes, Your Honor.
Okay, Ms. Scrub?
Thank you, Your Honor. Good morning, ladies and gentlemen. Good morning. Your Honor, Dr. Schweiger, defense counsel, colleagues. Dr. Schweiger, I'm going to have a couple additional questions before we turn to the various patient records. Are you familiar with metrics used in an ICU to determine comas, agitation, or pain?
Yes, ma'am, I am.
Okay. What are those scales or metrics used?
So, starting with coma, we routinely use what's known as the Glasgow Coma Scale, which looks at 3 parameters: eye opening, verbal, and then motor function. If someone is completely unconscious, the lowest score you can get is a 3, and if you're fully awake, conversant, following commands, you're a 15. Secondly, we have pain scores. The common ones that are used in ICU would be the COPT score, which usually grades in 4 different areas. And if you have significant pain, fighting the ventilator, muscle movement, you'd have an 8. That would be a maximum score, so 8 out of 8. Obviously, if you were not intubated, if you had no pain, were not fighting the ventilator, you'd have a 0. There's also, for non-intubated patients, there is a visual analog scale, which is assigned by the nursing staff, and that can be 0, no pain, all the way up to 10. And then we have what's known as the Richmond Agitation Scale, which grades patients depending on the perceived agitation of the doctor or the nurse in looking at the patient. And again, obviously, if someone is completely normal, they would be a 0. And then if they're excessively agitated, they get a positive score. And then if they're sedated down to coma, they would have a negative score. So that could be +4 on the high side, down to a -5 would be the lowest score.
May I approach you?
You may.
I'm going to present State's Exhibit 21. Could you please review and let me know what those are?
Did you show up the other side?
Do you want to see the CPAP, RES, and Glasgow again? We've seen these in time.
One more. I'm not sure it's but okay.
Thank you. Yes, so this is a document, did you want me to just quickly read, that basically includes protocol analysis of the Glasgow Coma Scale, how it's graded, followed by the Richmond Agitation Scale, also known as the RASS or RAS scale, and then finally there's a description of the grading for the critical care pain observation tool, including facial expression examples, body movements, compliance with the ventilator, and muscle tension.
Thank you. Your Honor, may Diane and I approach for just a minute? I want to
Sure.
Have a sidebar about an issue and straighten it up.
You guys got to meet Jason this morning? He's Judge Miller's bailiff. He's helping us out today. He'll entertain you. He says he can juggle. I don't know. You can talk to him out front.
Dr. Schweiger,
Hold on.
oh, I'm sorry.
Doctor, will you do me a favor? Can you put those reports away until I need it?
Certainly.
I would appreciate it. Counsel?
Thank you. Dr. Schweiger, in your opinion, based upon 30 years of experience as an anesthesiologist, critical care physician, and your experience as a medical school professor, and your experience training residents and staff, and to a reasonable degree of certainty, would the medical and pharmacological information that you presented yesterday be both accessible and generally known by others trained in your specialty areas?
Yes, within a reasonable degree of medical certainty, the information that I testified to yesterday is well known and accepted by practitioners in anesthesiology and in critical care medicine, and is well documented and known within the validated scientific and medical literature.
Thank you. Yeah, Your Honor.
You may.
I'm approaching the State's Exhibit 1. Could you please tell me what this is?
States Exhibit 1 are the printed out version of the electronic medical records for patient Joanne S. Belisari, who was admitted to Mount Carmel West on April 22nd, 2015.
Thank you. Are there pages numbered in this record as it appears?
There are no specific page numbers assigned to the electronic medical records.
Thank you. Is there a printed index in that medical record?
No, ma'am, there is no printed index within the medical records.
What does a person need to do in order to glean information from such a record?
So in order for a person to glean information from the record, one would have to review the entries made by the physicians and the nurses that documented within the medical record, usually starting with the patient's history and physical examination, which is essentially the first document that's filled out upon admission, and then the progress notes of the physicians, the consults of the various medical specialties, and then usually there's what's known as a discharge summary, which is when the admitting or primary physician summarizes the patient's medical record. So in order to glean information from the chart, particularly if it's not including an index or pagination, you'd have to methodically work your way through the medical record to identify and extract the information from the chart.
And what technology assists you in that?
So technology that would assist you, if one is reviewing the medical chart electronically, obviously one can usually go from one area of the chart more quickly than with the paper chart. But other than that, one really has to work oneself through the chart incrementally, again, trying to understand the temporal sequence of how the patient presented to the hospital, was evaluated and then cared for.
Thank you. And in preparation for your testimony today, how did you approach these records?
The methodology I utilized in an effort to try to avoid hindsight bias as an objective reviewer was to start with the patient's initial admission to Mount Carmel West and then work through sequentially from the first day of the admission up through the day of discharge, or in this case, the patient's death.
Thank you. And does this, in your opinion, demonstrate why documentation is important?
Yes, absolutely. When you have voluminous medical records of a patient, clearly documentation is very important in order to try to capture the critical events that have occurred during the patient's admission and treatment. That includes both the entries by the physicians, but also that of the nursing staff.
Thank you. Take it back. And Ms. Belisari was one of how many that you had to approach?
Ms. Belisari's case was one of 14 that I was asked to review in the manner that I described, and then author a written report.
Okay, thank you. And did you do so in each case?
I did, yes.
Great, thank you. Great, okay. Well, we'll start with something else, and then we can look. Okay, let's turn to Joanne Belisari. Did you review the records we just discussed in this lady's case?
Yes, ma'am. I reviewed the records at least 2 times in totality. First, prior to my initial report in the case, and then subsequently, about a year later, when I was asked to write an individual report on the case.
Thank you. Did you attempt to review the entire medical record?
I did, yes, ma'am.
Do you remember each and every fact from her medical record?
No, her medical record was several thousand pages. It would be impossible, I think, for any physician, nurse, or reviewer to remember every specific fact.
Okay. States Exhibit 32C, his report. Yeah. Okay. I'm going to present States Exhibit 32C. What is that?
States Exhibit 32C is a copy of the report that I submitted after my review of the medical records.
And counsel, you can go back and forth without asking, because you've got a lot of time.
I'm sorry, sir.
You can go back and forth without asking, because you've got a lot of documents to bring up there.
We'll be at it for a while. Your Honor, may I publish portions of the report?
Any objection?
This is between us. We don't even need to sign.
No, this is this.
Plus, there's some information. So, I'm going to make sure that it's covered, or at least we can approach when we get to that point, as far as what should be.
Sorry.
Oops. Is this guy on?
Should be. You gotta let it focus. It's got an autofocus.
It's doing absolutely nothing. I just turned it on.
It's starting to come on now.
There we go. Yay. Okay, this is, I'm demonstrating page 2, and Dr. Schweiger, what is discussed on page 2?
So page 2 is in essence a narrative description of the patient's presentation to Mount Carmel, giving a brief synopsis of her past medical history, followed by the presenting symptoms or chief complaint. In this case, it was seizures of new onset. And then towards the bottom of the page, in a tabular form, the physician has listed key elements of her past medical history.
Okay, thank you. And is there a reason COPD is listed first?
Yes, obviously, chronic obstructive pulmonary disease, or COPD, is a diagnosis that affects the patient's lungs, and so that would be a major issue in this patient's case. Also because it impacts some of the other diagnoses that are listed below, particularly the presence of pulmonary hypertension, which is elevated blood pressure within the lungs itself.
Thank you. How long was her hospital course?
Her hospital course was from April 22nd through May the 10th, so it was a little more than 2.5 weeks.
Okay. And do you recall when this lady went to the intensive care unit in this case?
Yes, she went to the intensive care unit after she had some respiratory deterioration, and I believe that occurred on or around May the 1st.
Okay. Would it help if I placed part of your record or your report indicating that Dr. Hussel was requested to evaluate her on May 1st? She was then transferred to the ICU, and what other things were going on with her as you see there?
So on May the 1st, the patient had an increase in their respiratory rate. You can see under consulting physician towards the top, it says that the patient was tachypnic, which means increased respiratory rate or breathing. The patient also had a change in mental status, meaning that the patient was confused, but still talking, and the lungs had distant breath sounds. So again, at this particular time, the patient had been placed on sodium bicarbonate to try to buffer her acidosis. And then there was a decision made to evaluate the patient in order to put the breathing tube in or to intubate, which would help the patient breathe on a ventilator. And that's listed towards the bottom of the page when it says that she had become very unresponsive and was only responding when the doctor rubbed on her chest. That's a sternal rub. And so the decision was made to go ahead and put the breathing tube in.
Okay, thank you. Then you have a note that Dr. Hussell again interacted with the patient on several days later.
May the 6th.
Yes. What does that note indicate?
So on that day, it appeared that the patient had become progressively agitated, and the patient was on a sedative known as Presidex at relatively low doses, 0.4 micrograms per kilo per hour. So upon the assessment and the fact that the patient had been agitated, and there was also concerns that the patient had regurgitated the feeds that were being given into the stomach, and there may be aspiration, which means that with vomiting or regurgitation, the patient could soil the lungs with the aspiration. So at that point, there was decision to suction the patient. They turned the tube feeds off, and the amount of sedation was tripled. It went from 0.4 to 1.4, and the patient also required more oxygen and adjustment of the ventilator, so the oxygen was put to 80%, and there was more positive pressure applied on the ventilator at +8.
Leading up to her demise, were there other procedures other than the intubation that this lady underwent?
Yes, the patient did undergo other procedures.
Could you please detail those?
So the concern in Mrs. Belisari obviously was, first of all, that she had presented with altered mental status, and the initial concern was that she had a diagnosis known as PRES, P-R-E-S, which is known as posterior, meaning the back of the brain, reversible encephalopathy syndrome. So the patient had undergone appropriate neurological imaging, including a CT scan to evaluate for that. The patient was also worked up for evaluation for obviously her colitis and her chronic kidney disease. So she had a series of blood tests that were done and documented in the record to evaluate her. And then because there appeared to be a concern regarding infection in the lung, she was started on antibiotic therapy in an effort to treat any underlying pneumonia.
Were there any attempted invasive procedures?
May I just review my report?
Please.
So Ms. Belisari underwent diagnostic bronchoscopy, which is known as an EBUS, E-B-U-S, which is when the bronchoscopy is combined with interpulmonary ultrasound in an effort to establish whether or not the lesion that was found on her chest CT scan actually reflected a malignancy or cancer. And so there was an attempt made to identify that, and the initial result of the EBUS was negative for malignancy, although again, there was still concern that perhaps they didn't get adequate tissue specimen to definitively diagnose the malignancy.
Thank you. Was there a time when she received the insertion of an arterial or peripheral line?
Correct. The patient actually needed both the insertion of the peripheral venous axis in order to administer fluids and blood. And then, as many patients who were placed on a ventilator, there was insertion of an intra-arterial catheter which allowed the treatment team to measure both beat-to-beat blood pressure measurement, but also to sample the arterial blood to measure the arterial blood gases.
Thank you. Was pain medication offered to her for those?
Yes, she did intermittently receive low doses of pain medication throughout her hospitalization.
Thank you. Was there a time when the nurse tried to switch the side of the insertion tube? Do you recall that?
Are you referring to the peripheral IV access, or?
The actual ventilator tube. Do you recall that?
I do recall that, yes.
Okay. I'm going to put up a handoff form from her medical record dated May 5th, which indicates that she had some agitation and that they could not change the tube or change the side of the ventilator tube. Do you recall that?
Yes, so on May 5th and then again on May 6th, there were attempts to perform what's known as spontaneous breathing trials, where there are efforts to wean the patient from the ventilator and allow the patient to do more breathing. Additionally, we usually attempt to move the position of the breathing tube in the mouth, because if you leave it sit on one side of the mouth too long, it can cause erosion into the lip and the gum to the other side. But as was documented here, she did not tolerate the attempt at moving the breathing tube because she had become very agitated. And in fact, at that time, she required the administration of both fentanyl, 200 micrograms, and a small dose of Dilaudid, 1 milligram, in order to try to facilitate the movement of the tube.
Okay, thank you. I'm going to present to you pages 1,282 versus 1,287, which are the pain scores for this lady. Could you please review?
Thank you.
Do you know all of these of your own personal knowledge and memory? Or is this refreshing?
It refreshes my memory, yes. I mean, I was generally familiar with the information, but in terms of each specific entry, I'd have to look at the chart.
Okay, thank you. And what would you say about her pain scores during the course?
So what those pages reflect was that the vast majority of the entries observed and made by the nurses is that Mrs. Belisari had either a score of 0 or was documented to be sleeping. There were a few occasional entries where she did have a score of 8. That was usually associated with procedural interventions by the nurses. And towards the end of the document, there was one entry where they have a narrative description of pain where the nurse described the pain as burning. Again, how she identified that is not totally clear since, Ms. Belisari had the breathing tube in eventually. But essentially, for most of her hospitalization, her pain was very well controlled or non-existent.
I'm sorry, Your Honor, we had the medication administration stuff separated and
It's in the upfront.
Doctor, do you recall of your own knowledge the full breadth of the medication administration record in this case?
No, I've not been able to memorize the entire medical administration record. It's quite voluminous given the 2.5 weeks of her admission.
Thank you. I'm going to present to you what is represented in pages 2428 and 2639, which is the MAR or medication administration record. Have you previously reviewed this?
I have, yes. This looks exactly familiar with what was included in Ms. Belisari's electronic medical record, including the detailed pages regarding the medications, and then towards the second part, the continuous infusions, which were broken out separately that she received during the admission.
So could we talk for a minute about the two parts, the continuous infusions versus the infusions or medications that are given in the regular part of the MAR?
Yes, ma'am. So when a patient is in the ICU, there's usually a distinction between those medications that are given intermittently, whether that's on schedule or requested by the patient. And that can either be through an intravenous, or it can be, if they're not intubated, through the mouth, or occasionally, even if they have a breathing tube in, the nurse can crush them and put them through the feeding tube to deliver the patient the medication. Alternatively, there are those medications that have to be continuously run into the patient. And as I mentioned, she had been on a medication called Precedex, and that medication needs to be continuous infused into the patient in order to control the patient's potential anxiety or sedation requirements. That medication itself has a half-life less than 10 minutes, So you couldn't really give it once every 2 hours or 4 hours. There'd be huge gaps in it. So whenever we talk about continuous infusion, it means that there's a pump on the patient's bedside, and it's putting through the IV tubing that constant medicine. And at Mount Carmel, consistent with what is done at other hospitals, they distinguish between the infusion of the two medications.
Thank you. Did you make notes as you reviewed the medication administration record of medications that were administered that you felt were important to note in coming to your conclusions?
I did, yes, ma'am.
Was this lady on continuous infusion of pain medication?
No, she was not. She would receive intermittently, when needed, she would receive IV bolus of pain medication. And then the infusion involved the Presidex, which primarily was used for sedation. It does provide a small amount of analgesia, but it's not primarily used as an analgesic medication.
Which physicians cared for Ms. Belisari in the intensive care unit at Mount Carmel West?
So obviously the admitting physician cared for the patient, and then I saw consultations by gastroenterology, Dr. Reddy. There was also Dr. Zangmeister, who was a hematologist, Dr. Agra, who was a kidney doctor that saw the patient. I also saw documentation in the record from obviously Dr. Hussel and the critical care team. So there were multiple treating teams that were providing consultation for the patient.
Thank you. Was this lady extubated on a certain date? And if so, what was that date?
Yes, she was ultimately extubated on May the 10th, 2015, when the breathing tube was removed from her airway.
Thank you. And was there medication associated with that extubation?
Yes, there was. Earlier that evening, shortly after, I think it was around 6:26 in the afternoon, she did receive Dilaudid for described breakthrough pain, but it was a small dose of 1 milligram. And then later that night, at approximately 11:32, which is 23:32 military time, Ms. Belisari received 1,000 micrograms of fentanyl intravenously.
Is that detailed in your report?
It is, yes. On page 7 of the report, I described earlier orders regarding fentanyl. Those were those that were received on April 30th and May 1st. And then the actual medications for the intubation were on page 8. And then lastly, what you had asked me, the medication received prior to the extubation was detailed on page 9 of the report, where I indicate the order placed for the 1,000 micrograms of fentanyl and the nurse confirming the administration.
Thank you. And who ordered that?
The order for the fentanyl on May the 10th, 2015 was Dr. Hussel.
Thank you. In your professional opinion, which we established yesterday would be within a reasonable degree of medical certainty, do you believe that it was appropriate to place this lady in the ICU and intubate her?
Yes, most certainly. Based upon her initial presentation and problem list, particularly the change that occurred in her brain, and then the subsequent workup that she was having to rule in or rule out the lung malignancy, plus her chronic medical problems, clearly by the time she was brought to the ICU, that was appropriate to stabilize her, and then attempting to place the breathing tube and putting her on the ventilator while a determination was made of her underlying medical problem, particularly the EVUS that had been done and whether there was lung malignancy or pneumonia. That was all appropriate.
Do you have an opinion as to whether or not this lady's situation was salvageable?
Yes. In reviewing Mrs. Belisari's extensive hospitalization, it's clear within a reasonable degree of medical certainty that she had many significant medical problems. But her care was certainly not at the point where I would describe her as imminently terminal or further options futile. And so if she had been under my care, I would have continued to support her to see whether or not her condition could have improved. And then again, if at that point she did not show further improvement, then a discussion could have been had. But I didn't see that imminent death was pending at the time the decision was made for the terminal extubation.
Thank you. On page 11 of your report, there's a paragraph, diagnosis during hospitalization. Can you talk a little bit about what's in that paragraph?
Yes, so as is demonstrated on the screen, the doctor that was providing the discharge summary listed some of the major medical problems that the teams were dealing with. Starting at the top, it lists acute on chronic hypoxic respiratory failure. And that's a common term we use in the intensive care unit. The chronic respiratory dysfunction relates to her chronic obstructive pulmonary disease, or emphysema. And what this term means that she had the acute exacerbation or deterioration on top of her underlying disease. And so that's why she was transferred back to the ICU on April the 30th. And then underneath that, the notation about having the breathing tube placed on the following day, May the 1st, intubated. And there was also the description which explains additively why she needed the support on the ventilator, because remember, she had chronic kidney disease, and so she had problems excreting fluids. So they list here that she had renal failure, which had worsened. Also, there was concern about associated pneumonia while she was in the hospital that they talk about, and they couldn't exclude the fact that she had aspirated the tube feeds, meaning material from the stomach coming up in the mouth and then getting in the lung. So that was all listed there. There was also, because she had a cavitary lesion in her lung, and they couldn't exclude whether that was a tumor with cancer or whether or not she had tuberculosis at some point that may have activated. The term mycobacterial infection refers to that. Below that, very importantly, they list that she had elements of septic shock. And again, this goes back to the theme I discussed. When we use the word septic, it relates to infection, and shock means the dysfunction within the body as a result of the infection. And they were attributing that pneumonia. And then again, they reiterate the point about the hospital-acquired or healthcare pneumonia and possible aspiration. The identification, when they cultured her sputum in the lab, they did grow a bacteria species, which was known as Echinella, and that can cause pneumonia. And she had been receiving antibiotics for that. They then also finally list two other important features that were related to her initial admission. The first being seizures, which was being treated by the neurology consultant with an anti-seizure medication known as Depakote. And that was important because although Depakote is very effective at controlling seizures, it can depress the patient's mental status and make them very somnolent and sleepy. So until they're used to Depakote, it can give the impression that the patient is not very responsive. So that may need to be controlled. And then, of course, she had the posterior reversible encephalopathy syndrome, or PRESS. And the key issue, press obviously occurs because the patient's blood pressure is out of control. So that causes abnormal pressure in the brain, and as the title explains, it's reversible. So although it's severe, you have to first control the blood pressure and then allow time for the swelling in the brain to go down. And so they list that that was related to uncontrolled BP, and also she had been on some immunosuppressant medications for her rheumatoid arthritis, and there was some discussion whether or not that also may have impacted some of the additional diagnoses that were described above. For example, if you're immunosuppressed, you're more likely to get infection or have a tuberculosis that otherwise would lay dormant come out. So they had stopped the immunosuppression on this hospitalization, but again, it had not been off for a long period of time.
Thank you. Aside from that issue, did you find that some of the procedure used leading up to, do you have an opinion as far as the procedure used actually leading up to the extubation?
Yes, I do have an opinion.
What is that opinion?
So in reviewing the chart, I noted that there was no clear documentation on the day of the terminal extubation regarding a status update given her condition, and there appeared to be a relatively quick decision for terminal extubation, even though for the most part her condition through the hospitalization, with certainly the deterioration around April 30th and May 1st that required the intubation, had either shown some improvement, such as with the changes in her brain, or had shown some stabilization. So again, the lack of a detailed progress update and the lack of a multidisciplinary discussion, given that there were multiple consultants involved in her care, appeared to be inappropriate at that period of time. Also, Ms. Belisari had received small doses of fentanyl when she came to the ICU, and additionally a dose of fentanyl for the intubation that was much below the order for the terminal extubation. And again, in terms of potential pain or discomfort, putting the breathing tube in is much more painful than removing the tube, which often has no pain at all.
Thank you. Was a discussion of this lady's DNR appropriate?
Yes, certainly. I believe that the decision to discuss the do not resuscitate status of the patient, given the numerous medical problems, and of course that in fact was appropriate, and I think to establish that with family or next of kin certainly was appropriate during her ICU admission.
Thank you. Is it your opinion that the extubation itself was appropriate?
No, that is not my opinion. In terms of at the time that the extubation occurred, again, I don't believe that all medical interventions had been exhausted or that the patient had been given an ample time to declare herself whether or not her conditions could be reversed.
Had she just completed a course of antibiotics the day before?
Yes, that's correct. And as mentioned in my earlier response, she had finished the Zosyn. She had a 7-day treatment. But given what was described in the record, both by pulmonary as well as the other consultants, about potential for tuberculosis, obviously tuberculosis is difficult to diagnose, even with immunosuppressive therapy, and even more difficult to treat. It usually requires months of treatment, not simply a 7-day course of antibiotics. So absent a definitive diagnosis of both the lung mass, which, as I said, the initial impression was it was not a malignancy, but there was still concern that that was missed, and or that she may or may not have ongoing infection of the lung, including both the concern about the aspiration pneumonia, which is contamination from above, as well as the concern about mycobacterium or tuberculosis. This would not have been considered complete or adequate treatment.
Turning now to the actual extubation. At what level of anesthesia would this woman's pain be appropriately addressed before or during the extubation?
So again, in terms of the adequate layer of analgesia, there were multiple entries in the medical record from days earlier that her pain was well controlled with very small amounts of fentanyl or Dilaudid. And again, then in reviewing the pain scores that were described, it certainly appeared that for most of her ICU admission, she had either no pain or sleeping or just intermittent breakthrough pain. So one would anticipate that standard doses of analgesics would have been more than adequate to control any theoretical pain that she may have had related to the extubation. And again, although there was a concern about cancer, she did not have a diagnosis of cancer, nor was there any description in the days or weeks leading up to the extubation that she had any pain related to cancer.
Thank you. What would be accepted medical practice in your hospital or in your practice as far as the actual dose?
So in terms of my practice and at my hospital, we would have started by giving her, if we had agreed with the policy and protocol I mentioned earlier, everyone was in agreement to proceed, a administration of 2 to 4 milligrams of morphine would have been a good starting point, or alternatively administer 1 to 2 milligrams of Dilaudid, especially since she had tolerated 1 milligram of Dilaudid earlier. That would have been preferable in terms of her pain relief. If the choice had been made to give her fentanyl, then given her age, her underlying kidney function, a dose of approximately 100 micrograms, which was similar to what she received in the earlier phase of her hospitalization, and what would have been 1/10 the dose that was ultimately given, should have more than adequately controlled any pain she may have experienced.
In your opinion, would a reasonable and prudent critical care physician trained in anesthesia know the effects of the drug given to this lady at this dose level?
Yes, absolutely. In terms of what a reasonably careful and prudent anesthesiologist would learn early in their training, within the first month of our education, we are lectured and expected to learn the pharmacology of the narcotics or opioids. So certainly anyone who had completed an anesthesia residency would be familiar not only with the pharmacologic effects of the drug, but the appropriate dosing of the opioids moving forward.
Was there any legitimate medical reason for this dose of fentanyl in this woman?
No, in performing a careful prospective review of the events that occurred on May the 10th, I could find no medical justification for the administration of fentanyl at 1,000 micrograms at the time the decision was made to terminally extubate Mrs. Belisari.
What purpose could this dosing serve at this level?
Objection, Your Honor.
I'll permit it.
Thank you.
Given her underlying medical history, given the events that had occurred during the 2.5-week hospitalization, and the fact that there was no true medical justification for a dose of 1,000 micrograms of fentanyl, the only pharmacologic effect that one would anticipate is central suppression of the respiratory cycle within the brain, because again, fentanyl's onset in the brain occurs within 1 to 2 minutes, resulting in central apnea, which would then blunt the patient's ability to breathe, and also blunt the ability of the patient's brain and lungs to respond to a buildup of carbon dioxide, which would otherwise trigger breathing. So at 1,000 micrograms, more likely than not, within a reasonable degree of medical certainty, a patient such as Ms. Belisari would become apneic very rapidly. And of course, with the apnea, the inability to breathe, death would be imminent within 5 to 10 minutes.
In your opinion, did the dosing of 1,000 micrograms of fentanyl hasten and/or cause her death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, the decision to administer 1,000 micrograms of fentanyl, which was, I believe, received at 11:32 p.m., did cause and/or contribute to the hastening of Ms. Belisari's death through respiratory suppression, apnea, and then eventual cardiopulmonary cessation approximately 8 minutes later at 11:40 p.m.
Thank you. I'd like to approach the bench, Your Honor,
You may.
with counsel.
Jason, if you'd be kind enough? Is Jason entertaining, guys? No? The jury's still out on you. Okay? Okay. You ready, Madam Court Reporter? Ms. Grubb?
Thank you, Your Honor. Dr. Schweiger, do you understand or are you conversant with the concept of the doctrine of double effect?
Yes, ma'am, I am.
And why is that?
So for two reasons. One, my undergraduate degree was in religion and philosophy, so I studied St. Thomas Aquinas and his writings. He was a theologian in the Catholic Church in the Middle Ages who first put forth the doctrine of double effect. But then in medical school, we were educated in regards to the application in medicine. So for example, there are times when doctors are asked to provide therapy that have known side effects. A good example is chemotherapy. You're giving chemotherapy in order to cure cancer, but you know it's going to cause a patient's hair to fall out. It may give some numbness or tingling in the fingers. So as long as one is guided by what's known as the rule of proportionality, meaning that the benefits of the treatment outweigh the potential risks, then the rule of, or the doctrine of double effect could be applied in terms of our choice of medical treatment or therapy.
Thank you. And what does the doctrine of double effect do to speak to the acts of a physician?
So the general principle of the doctrine of double effect always speaks to the need for the physician to do a risk versus benefit analysis. The doctrine, both when put forth by the medieval theologians as well as by modern physicians, isn't meant to just give a carte blanche that doctors can do whatever they want by the understanding that there may be a side effect, but rather going back to that concept of proportionality, using, in essence, the scales of justice. You try to weigh, are the risks of the treatment going to be more beneficial to the patient than the potential adverse side effects? So, for example, you can cure cancer by giving a patient cyanide, but that means that you kill them. So that obviously, there's no proportionality there. You couldn't use the doctrine of double effect saying, I am treating cancer by resulting in the death of the patient. That would be illogical, and it would not be supported by the doctrine of double effect. So there has to be a concept of moderation and proportionality. And then when doing that, particularly in medicine, as we've gotten more advanced and we have more drugs, more techniques, it becomes important for doctors to weigh the risks and benefits when offered to the patient.
Thank you. In your opinion, does the doctrine of double effect have application in this case?
No, I do not believe in studying Mrs. Belisari's medical records that the doctrine of double effect could be used as a rationale on May the 10th to administer 1,000 micrograms of fentanyl. Because again, going back to what I mentioned just a minute ago, if you look at the concept of moderation or proportionality, she had tolerated much smaller doses of both fentanyl and Dilaudid and achieved pain control. So that would be the moderation. So in order to then go and give essentially 10 times the dose that she had received earlier would seem disproportional to her pain scores, disproportional to what she may experience during the removal of the tube. And given that she had an altered mental status at that time leading up to that, it would be unlikely that she would suffer extreme pain, extreme fear, extreme agitation. So in my opinion, the doctrine of double effect is not applicable in the analysis of Ms. Belisari's case.
Thank you, Your Honor. Thank you, Doctor. Doctor, do you have an opinion as to what actions or lack of action taken by Dr. Hussel speak to his intent in this matter?
Yes, I do have an opinion.
What is that opinion?
My opinion is that in reviewing the medical record the lack of a formal multidisciplinary consult on May the 10th, the lack of involvement or consultation of palliative care, the lack of clear and identifiable documentation in advance of the decision to proceed with terminal extubation and removal of the breathing tube, given her medical history and course, and then the relatively excessive dose of fentanyl at 1,000 micrograms speaks to the intent of Dr. Hussel, who gave the order for the fentanyl as well as the decision to proceed with the terminal extubation.
And what, in your professional opinion, what do you believe that intent was?
Objection, Your Honor. Allison answered.
I'll permit it.
In my professional opinion, which I render within a reasonable degree of medical certainty, the only plausible explanation for administering 1,000 micrograms of fentanyl on the evening of May 10th in advance of the terminal extubation would be to result in the accelerated death of Ms. Belisari by respiratory depression and apnea, because there would be no other plausible explanation to administer such a large dose at the time of the terminal extubation, given what was known about her neurologic, respiratory, and kidney function, as well as her relatively advanced age. It would be more likely than not, given that dose, that she would rapidly succumb after the extubation, and that, in fact, is what occurred.
Thank you. Thank you, Dr. Schweiger. We are now going to move on to the next case, which is the matter, count 2 of the indictment as alleged, be the murder of Ryan Hayes.
Wait, I'm sorry. Wait.
Count 2 of the indictment. As alleged, the murder of Ryan Hayes. That's why we're here. It's an alleged murder. Thank you. I'm going to approach the witness stand, Dr. Schweiger, with State's Exhibit 2.
Yes, ma'am.
Thank you, sir. What are
So these are the medical records from the admission of Ryan Hayes, who was admitted to Mount Carmel West on April the 2nd, 2017, through the emergency room after transport by the EMS system.
Dr. Schweiger, have you reviewed these records?
Yes, ma'am. I have reviewed those records carefully in a prospective manner.
Did you also review a coroner's report for Ryan Hayes?
Yes, I was provided the coroner's report and toxicology data, meaning that they sampled Mr. Hayes' blood after death to determine what substances were found within his bloodstream at the time of death.
Okay. I'm going to present State's Exhibit 18P. Does this establish that the blood was anti-mortem?
Yes, I misspoke. So actually, anti means before death. So on the attachment of the toxicology, it actually was anti-mortem blood.
Okay. And Dr. Schweiger, did you review this document before you wrote your report?
No, I was presented that document after I wrote my report.
Okay, thank you. We'll address it in just a minute. Do you recall what Mr. Hayes' reason for going to the hospital was?
Yes, so Mr. Hayes was relatively young. He was 39 years old. He had a history of substance abuse. Apparently, he had had, I believe, dinner with his sister, with whom he was staying at the time, and then told his sister that he was going to draw bath water and take a bath. When he didn't present and she heard the bath water still running, she then investigated and found Mr. Hayes unconscious in the bathtub. So that at that point, she called EMS, who were dispatched to the home and attempted to resuscitate Mr. Hayes with both basic and advanced cardiac life support. And given his history of polysubstance abuse, I believe also administered the reversal medication known as naloxone. And because they weren't sure whether or not he had taken any narcotics, they chose to give him the naloxone in an attempt to reverse him.
Thank you. And what was the length of his course of treatment?
He was admitted to Mount Carmel West on the 2nd, and he passed away on April the 4th of 2017, so it was approximately 2 days.
Thank you. On page 2 of your report, you indicate an assessment, and it indicated disposition of this patient within the hospital. Could you review that for us?
Yes, so here under the assessment, again, it mentions that under where I wrote next page, that the patient had been found asystolic, which meant at the time EMS came, he had no electrical activity on the EKG. He received multiple shocks by the EMS and also several rounds of adrenaline, which is the medication epinephrine, and then a medication to reestablish electrical stability of his heart. That's the amiodarone. And it required a fair amount of work by EMS before he returned to spontaneous circulation, that being his heart beating on its own. Both the sister who found him and then EMS were unsure of how long he had been in cardiopulmonary arrest, because again, it was unwitnessed directly. So he had been intubated, and because of the cardiogenic shock, he had been started on vasopressors to support his blood pressure. And again, the patient was appropriately transferred to the ICU and was stabilized there initially. And then it was decided that the patient would not want to have chest compressions if another code occurred. So that's why DNR CCA, which means basically comfort care in the event of another arrest, was entered. And then at the bottom they list that he had really a cardiac arrest and then acute hypoxic, meaning low oxygen respiratory failure.
Thank you. Was this individual appropriately intubated?
He was, yes. Whenever a patient is in asystole, they absolutely require support of their airway because they're going to be unable to breathe as a result of the inactivity of the heart. And then because he needed both basic and then more importantly advanced cardiac life support, including the defibrillation and multiple rounds of medications, it was very important that his airway was in fact secured, and since the patient did not immediately regain consciousness, he needed mechanical ventilation.
Thank you. Do you find that the documentation leading up to his final day in the hospital is adequate to explain what happened next?
So in terms of the doctors who were providing consultation, there was detailed explanation regarding what they were thinking and what the treatment options were. But then in terms of the terminal decision to move to extubation, once again, there was a lack of appropriate documentation as to the thought process or the specific inclusion of the multidisciplinary approach or palliative care in the process of determining whether or not Mr. Hayes should be extubated or receive terminal extubation.
And based on your experience and knowledge, is there sufficient information in the medical record to determine that this individual was terminal?
No, given his relatively youthful age of 39, as well as that it was an unknown downtime, one would want to allow the patient that period of time that I discussed previously to declare himself. Certainly the features of his arrest pointed to an ominous outcome. You know, the fact that he didn't respond immediately to resuscitation, that he was found asystolic, and that his pupils were found in the emergency room to be fixed and dilated certainly speaks to an adverse outcome. But again, usually these patients, particularly given that his initial arterial blood gas did show relative stability and not severe acidosis, one would want to give him the benefit of several days to see whether or not he did have any life still remaining within his body.
Thank you. If he had presented in your ICU, what procedures or medications would you have employed?
So for out-of-hospital arrest and given his youth, first of all, we would have attempted to cool the patient with targeted temperature management in order to protect the brain from further injury or swelling. Additionally, some element of sedation to reduce the oxygen requirements of the body during the first few tenuous days, both while he's being cooled and then coming out of the cooling, would have certainly been appropriate. Aggressive attempts to control his acidosis would have been appropriate, whether or not that required just the administration of sodium bicarbonate or the institution of other means of controlling his acidosis would have been appropriate. And then, of course, detailed neurological exams to make sure there isn't an improvement in his condition. Certainly, again, the concern was for brain injury. And then if there was a concern, a detailed neurological exam, including an apnea test, would have helped guide our decision moving forward on what his prognosis would have been.
Thank you. Have you reviewed the pain scoring for Mr. Hayes?
Yes, ma'am, I have.
The pain scoring for the record, the Hayes case, appears between pages 204 and 205. I'm going to hand you those pages. Does that refresh your collection?
Yes, ma'am, it does.
What pain level was documented for Mr. Hayes?
From the time Mr. Hayes arrived at Mount Carmel West up through the decision for the terminal extubation, he essentially had a consistent pain score of 0.
And then what happened at the point of the extubation in the pain scoring?
May I just look at the document one more time?
Sorry.
No, I just want to give an accurate response.
I ran away too.
No, thank you. I apologize. So what occurred was that on the very late evening of April 3rd at 22:57, for the first time, his pain score was indicated to be a 10, and that was using the critical care pain observation tool, or CPOT, and then it was listed as a 10 at 2257 at 2316, again as a 10, even though the upper limit of the CPOT is only an 8. So that really made no sense to me. How could it be a 10 when the maximum score could only be an 8?
Did you review the Glasgow or RAS scores for this individual?
I did, yes.
What were those?
Mr. Hayes' Glasgow Coma Scale was a 3, meaning that he had no spontaneous eye opening, he had no verbal response, and he had no motor movement to command. So that would be the lowest score that would be able to be detected on the Glasgow Coma Scale. And then he had a significantly depressed RAS score.
Thank you. Do you believe a discussion of a DNR was appropriate in this case?
Yes, given the circumstances of his arrest, as well as his initial response to EMS and the concerning findings in the hospital that I described earlier, both on the neurological exam and then his essentially lack of arousal after he was admitted, I certainly agree that a discussion with the next of kin regarding DNR status was in fact appropriate, because certainly if he had suffered another cardiopulmonary arrest, it is more likely than not he would not have definitely survived that or recovered. So it was appropriate and humane to discuss the future DNR status while at Mount Carmel West.
Have you reviewed the medications given to this patient while hospitalized?
I have, yes, ma'am.
And what were those medications?
So in looking at his medications, obviously he received up until the, do you want me to look at the MARS real quickly? Or
I can,
if may?
sure.
Yeah, I think that.
For the record, the MARS in this case appears at pages 399 to 415.
Thank you. So in terms of the intermittent medications, he had received sodium bicarbonate to correct the underlying acidosis. He was administered insulin on a sliding scale to avoid elevations in his blood sugar. He was given a medicine to avoid excessive acid in his stomach, known as Protonix, Protonix. And then he was also given heparin to avoid any blood clots. And then in terms of the sedative medications, he received none until the decision for the terminal extubation. And the same in regards to pain medicine, he did not receive any until the decision for the terminal extubation. In terms of the continuous infusions, that which is given every minute through the ICU, he was receiving the medication Levophed, Levophed, which is a vasopressor meant to increase his blood pressure.
And what medications were given or administered to Mr. Hayes in relation to the extubation?
So in relation to the extubation, Mr. Hayes was ordered, again, 1,000 micrograms of fentanyl. That order was placed at 10:53 p.m. And then he also had an order placed for Dilaudid at 10 milligrams, and that was placed at 10:53 p.m. And then additionally, there was an order placed for Versed, the midazolam, at 10 milligrams IV push at 10:53. And then there was an additional order placed, and that was timed at 11:15 for a second dose of fentanyl, 1,000 micrograms IV push.
Thank you. Could you determine in the medical record any reason in between those doses for the second round of dose?
No, there was apparently no specific indication other than this aberration of the pain score that was listed by the nurse, which again was inconsistent with his clinical examination leading up to that or any other pain score prior to that. But there was no description in the medical record that would have indicated a need for the high doses or the multiple administration of medications. In this case, he received 2 separate narcotics or opioids, the fentanyl and Dilaudid, but then the additional medication of the fentanyl.
May I reapproach, Your Honor?
Certainly.
Why don't we take a break first? It's been an hour and a half. Mr. Phillips, let's call everybody up.
All rise.
Ladies and gentlemen, enjoy your break, 15 minutes. We'll get started at 15 till. You may be seated. Ms. Grubb, anything for the record?
No, Your Honor.
Ms. Nashi?
Yes, Your Honor, but I'd like to do it once the witness is outside the courtroom.
Okay. Sir, you're excused. Remember my instructions yesterday?
Yes, Your Honor.
We'll see you back in 15 minutes. Yeah. Ms. Menashe?
Thank you, Your Honor. Your Honor, I just wanted to note, I've certainly let it go, but I think at this point it warrants putting on the record that we are getting and/or actually at a cumulative point with respect to the evidence at this point. It is 10:30. We started at 9. There's been very few sidebars to eat away at time, and we aren't even through 2 patients. Dr. Eli testified. I think the record speaks for itself as to whether and how much crossover there is in the same document shown to Dr. Eli. But, Your Honor, I think at the pace we're going over an hour per patient, I think it certainly warrants the court's consideration as to cumulative.
Okay.
Your Honor, I don't know how the state can doctor to opine unless we place on the record why he's doing it and his various reasons. He is not the same boarding as Dr. Ely. His practice is different than Dr. Ely, and he has different opinions than Dr. Ely. The opinions are similar, but they're not identical. And I feel that the state of Ohio is deserving of a full examination of our witness. This case is too important to the people of this state and to the defendant to not have a full and fair airing. I will say this. Ms. Belisari was one of the longest hospitalized patients. She's one of the older ones and has a more complicated medical record. I think the medical record is in like 3 volumes, 2 or 3 volumes. So getting through her was important. We have many upcoming alleged victims whose stay was under a day. So those cases will go very quickly.
Okay. And look, is there something you want to add?
Not to this topic.
Okay. Looking at 403, I agree the foundation's differently in the specialty, so I'll permit it at this point in time, but you would have covered, after we get to this witness, I think you've covered the whole aspect. But it's not cumulative at this point in time. Okay, next issue?
Yes, Judge, we at this time would like to address the improper and outrageous conduct by Ms. Grubbs in the last exchange of this witness. When she improperly started with her commentary about the murder, now I want to discuss the murder of Brian Hayes.
Okay.
That's not a question. It's an outright argument, and it's a conclusory argument. And I was thrown back by it so much before we objected that I wanted to make sure we heard her correctly. And at that time, I brought it to Ms. Menashe's attention, who was busy retrieving documents at the time. We asked that she come over to us so we could speak with her briefly, quietly, off the record, to confirm that that's what she actually said. Ms. Grubbs, I've heard her over the course of a month speak low many, many times, but at this time she decided to create a closing argument again and say, yes, the murder of Brian Hayes, that's why we're all here. And so much so that utilizing the word murder 3 times in front of the jury, I think it was a outrageous outburst on her part, strictly geared towards shock appeal, and so that the jury could hear what she was saying. Now, if that kind of conduct is permissible in this courtroom, I have plenty to say to the prosecutors in between questioning, and plenty to say about Dr. Hussel's innocence and how he's wrongly being persecuted in this case. And I could get up here all day and have this type of commentary, but I certainly don't think that's proper in any courtroom, and that's why I bring it up to your attention, and I ask that the prosecution be admonished for such behavior, and that it not be permitted to happen again. And we would also ask that the jury disregard Ms. Grubbs' extrajudiciary comments, because they're not in the line of questions. They were completely improper and borderline prosecutorial misconduct.
Okay. Well, factually, she said alleged murder when she was there, even though there was a pause between the two, and even though she was facing one direction and went the other direction, she did have the alleged beforehand. Okay?
It's still not a question. It's not a proper question. She's she's sitting there talking about what she's going to do about the alleged murder. I didn't hear the word alleged, which is understandable, because that's why I needed to clarify for her. But I heard the word murder, and for her, and I know there was not a question pending, and it was not in relation to a question. She has no right to get up there and give a conclusory comment about murder without asking any questions to the witness. And I think that is the issue that's improper here.
Okay. This was the directional comment that she made going to count 2. I just want to make sure we're talking about the same incident.
Yes, sir.
Okay. Ms. Grubb.
Thank you, Your Honor. I did use the term alleged. It was a transitional comment, which I think we have to use to turn from one count to the next. And this is a murder trial. There are 14 counts of murder alleged. And I think we ought to be able to use the name of the crime that we're here for. So if the court feels that I overemphasized it, I'm sorry. I will make sure not to use it 3 times in a row or twice in a row. But my intention was to focus everyone on to count 2 of the indictment, which does allege the murder of Ryan Hayes.
Okay. Anything else?
No, Your Honor.
Anything else?
Yes, sir. First of all, I'm fascinated by this new evidentiary concept called transitional, which we have objected to repeatedly in this case. That aside, it does not give a lawyer the right to make commentary, which is the ultimate decision of the jury. And I agree, we're here for a murder trial. So when I ask a witness, did you conspire to commit murder with Dr. Husel, I should be permitted to ask that question, but instead it's objected to because, oh, I mentioned the murder word. So, you can't have your cake and eat it too. And in light of this, it still sidetracks the main issue, which she got up there and made a comment that was a conclusory comment to this jury without a question pending. And then she came over here and spoke loudly and mentioned the word murder 3 times. And that's why we're all here, for a murder case, because of the murder. And she knows that's improper. Absolutely knows it's improper. To sit here, we're trying to speak to her and clarify an issue. And she intentionally blurts out our conversation loud enough for the jury to hear. That's a problem. That's not proper conduct in a courtroom. She knows better. And while I never tried a case about her, I know enough about her background to know that she knows better. And having said that, I think it's impermissible, and it shouldn't be tolerated.
Okay. In reverse order, addressing your argument, 611C deals with leading questions. Transitional questions are always permitted, okay? I don't know what you're basing your concept on, but it's been a common practice if I'm switching subjects to be able to use leading to go into the subject to switch it. Now, as to being testimonial or anything, that's a different issue, and it's question by question, okay? Relative to her comments there, both sides have been addressing in with the concepts of co-conspirators on your side versus this murder thing. It is 14 counts of murder. The alleged murder in transition, I do not feel that that's prejudicial to you, okay? The repetitive nature is due to the number of counts. I would ask the state to not highlight it for every count. I mean, you have to transition. The offenses occurred in count 2 or something like that, but it eventually does get cumulative in effect. So let's go through it guardedly, okay? I do not particularly care for the comment about transition made by you, Mr. Baez. It's 611C, okay? Ohio Rules of Evidence. So as to any objection on that, I don't feel it's well-founded. Anything else?
The only other issue that I would ask is that she not show me documents. She knows I'm not on the floor. There's nothing I could do in reference to documents being shown. I think it's a bad look for the jury for her to be showing me documents and I have to ignore her or point her in Ms. Benashi's direction. She's done that repeatedly. If there are documents that she needs to disclose to Ms. Benashi, I ask that she do it directly to Ms. Benashi. I don't want to get in trouble with the court, and I'm trying to respect the court's rules, and for that reason, I ask that she be so instructed.
Okay. I have my rule from day one. I've told everybody, the one on the floor is the one who's involved. Was Ms. Benashi not available?
She had her back turned and was talking to, I think, co-counsel. And for context, what I was presenting was, I believe, part of the medical record, which has been stipulated, and it was a pro forma, here it is kind of thing.
Okay.
But if that's not acceptable, I stand admonished.
I have been consistent from day one. The one on the floor is the one who deals with issues. Okay? So we'll leave it at that. Anything else for the record?
Your Honor, I believe Mr. Zion wants to
Yes,
address
Mr.
it.
Zion?
Want to do it at noon, or?
Yeah, it's nothing that we've talked about at this point. It's my understanding at the sidebar there was some talk about the lessers and stuff, and I would just like to put that on the record and discuss that a little bit. But that's nothing we can do now. I'm sure people have a few minutes to go to the bathroom.
Okay. We will stand in recess. We'll get started at 15 till, which is 3 minutes. I think we might not start at 15 till because I know my court reporter needs a break.
Do you all want to see the MAR again? Or to revisit something with? I'm going to represent the medication administration record and ask you to re-review all of the dosing adjacent to the extubation in this case.
Yes, ma'am. I'm ready.
Would you like to revisit any of your answers with respect to the amount of medication offered and administered to this patient?
Yes, so the first round of medications that was given at 10:57 included 1,000 mics of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed. And then the medical administration record indicates that 19 minutes later, which would have been at 11:16 p.m., the same round of medications were given, including 1,000 micrograms of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed.
Thank you. Doctor, would a reasonable and prudent critical care physician trained in anesthesia know the effects and the combination or the combination of effects of the drugs employed in this case?
Yes, a reasonably careful and prudent anesthesia and critical care doctor would know the pharmacology of these three medicines, both individually and when combined collectively, as well as the doses at which these were being given.
Is there any legitimate medical reason for these doses?
No, given Mr. Hayes's presentation to the hospital, his lack of neurological improvement during the 2+ days that he was at Mount Carmel West, there would be no justifiable medical indication to give these medications at these particularly elevated doses to Mr. Hayes in preparation for or during the terminal extubation process.
Doctor, at what level of anesthesia would be appropriate?
So given that he had essentially 0 pain scores and a Glasgow Coma scale of 3 preceding this, very low doses of opioid or narcotic would have been indicated, again, probably on the order of 2 milligrams of morphine, or alternatively 1 milligram of Dilaudid, or alternatively a maximum of 100 micrograms of fentanyl. Certainly, I don't believe any reasonably careful or prudent anesthesia critical care doctor would have given 2 opioids at the same time to Mr. Hayes. Again, given his situation, 1 would have been appropriate, and then careful observation and, if need be, incremental dosing of that 1. But there'd be no reason to give both fentanyl and Dilaudid to the patient.
Doctor, would you like to see the autopsy report and toxicology report for the anti-mortem blood again?
Yes.
Can you tell us what substances that could qualify as a narcotic, opioid, or opiate appeared in the toxicology report for Mr. Hayes?
Yes, so on the first page of the toxicology, they indicated that there was fentanyl found, and then also that there were generically opiates found. And then on page 2, They indicated that there was some element of ethanol. Of course, that's not related to opioids. They found cotinine, which is a metabolite of nicotine from cigarettes, in his blood. They did find that there was morphine present. They found the naloxone, which was the reversal agent given by EMS. And then they found carfentanil, which is a metabolite of fentanyl, in his blood. Although it wasn't quantified, they just said positive on the toxicology report.
Thank you. Knowing now the contents of this toxicology report, does that affect your opinion in this case?
No, ma'am, it does not.
Why not?
Again, because what would indicate both the need for opioids at the time of terminal extubation and withdrawal, as well as the dosing, would be the patient's clinical presentation leading up to that decision, meaning how the patient was presenting in the intensive care unit, what his Glasgow Coma Scale was, what was the observed pain scores. Those are the determining factors at what dosages you would prescribe pain medication for the patient at the time that the decision was made to terminally extubate and or to withdraw support.
Thank you. In your opinion, did the dosing offered or administered to Mr. Hayes hasten and or cause his death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, both the choice of the three medications that I listed, the fentanyl, the Dilaudid, and the Versed, as well as the excessive dosing of those three medications, and then the decision to repeat them, did cause and or contribute to the death of Mr. Hayes on April the 4th. Of 2017.
Thank you. Was there any legitimate medical reason for this dose of fentanyl or these doses of medications?
No. Given what is documented in Mr. Hayes' medical record, and particularly the observation of the nursing staff as to what his pain scores had been, as well as the physical examination and documentation of neurological exam, I can not come up with any medical justification for the decision to choose these medications at the time of the extubation or the dosing schedule that was applied to each of the three medications. And certainly, given that the medications had just been administered at 22:57, there's no reasonable explanation for why a decision was made to then repeat the dosing 19 minutes later.
Thank you. What purpose could this dosing serve?
Within a reasonable degree of medical certainty, the purpose of giving these three medicines in combination at the doses they were ordered would serve to essentially hasten the patient's death and demise after the breathing tube had been taken out, given that it would more likely than not, within a reasonable degree of medical certainty, result in the patient to rapidly stop breathing due to central apnea, and would most definitely impede or impair his ability at the brainstem level to respond, both to an increase in his carbon dioxide as well as a drop in his oxygen level. He would physiologically thus be unable to respond by triggering breathing, and it would then result rapidly in his death.
What actions or lack of action by Dr. Hussell speak to his intent in this matter?
So once again, the lack of appropriate inclusion of the various treatment teams with multidisciplinary involvement, the lack of consultation of palliative care, the lack of appropriate documentation in the patient's medical record as to why a decision was being made essentially in the middle of the night to proceed with terminal extubation and withdrawal of support, the lack of a specific order for terminal extubation placed in the medical record, and then the entries in the medical record concerning the choices of the medication, the dosing, all speaks to the intent of Dr. Hussel, who ordered these medications and ultimately was responsible for the terminal extubation withdrawal of support.
What do you believe his intent was in this matter?
In my professional opinion, within a reasonable degree of medical certainty, it appears from studying this medical record and the dosing that the intent of Dr. Hussel in ordering these medications at these doses was to cause the patient to rapidly stop breathing and thus to hasten his death.
Thank you. Thank you. Doctor, let's turn the page to Beverly Schertzinger. I won't repeatedly approach. I'm holding her medical record, States Exhibit 3. Did you, in fact, review States Exhibit 3, her medical record?
Yes, consistent with the methodology I employed in the previous two cases, I carefully reviewed Mrs. Schertzinger's record prospectively, meaning from the time of admission through the course up until her death.
Thank you. To the best of your recollection, why did she go to the hospital?
So the reason that she presented initially was because she had had a progressive cough that was initially treated as an outpatient with a Z-Pack about a month previously, and she also had had a low-grade temperature. But as a result of that cough, she then had what was described as choking spells, and then she fell, and that resulted in a bruise around her calf. So she was concerned that she might have or develop a blood clot in her leg. So she presented for evaluation, and then she had had imaging of her chest at the Grove City emergency room, and that was suspicious that she might have a cancer, specifically a type of cancer known as bronchogenic carcinoma. So then she was referred to Mount Carmel West for further workup of the possible malignancy and determination as to what treatment protocols could be offered her for that.
Thank you. Did you review her various lab values?
I did, yes, ma'am.
Okay. Could you discuss her hospital course?
Yes, so after she was admitted, the treatment team realized, first of all, that she had other underlying medical problems. Most notably, she had what's known as aortic valve stenosis in her heart. She also had some stenosis or blockage in her carotid arteries in her neck, for which she had previously had surgery on the right. But most notably, they determined that she had a long-standing history of tobacco usage. She had smoked since she was 15 years of age, and that increased the risk that she actually had lung cancer. Also, there is a type of lung cancer which can result in an endocrine syndrome known as the syndrome of inappropriate antidiuretic hormone release, or SIADH. And they were concerned about that in Ms. Schertzinger because when they looked at her laboratory values, they discovered that she had a very low sodium content in her blood. And as a result of that, they needed to work that up as well. So when they determined that, they initiated medical management to try to stabilize her sodium content, but that initially did not work. So they included additional consultants on her case, including the kidney doctor and the nephrology, which is the nephrology consult, to give advice on how to bring that under control. They also included the need for pulmonary to, again, do a bronchoscopy and look inside her lung to try to better identify what type of lung cancer she had, because the CT scan not only showed the mass, but it showed she had some lymph nodes that were swollen and may infer that she had what's known as metastatic disease, meaning the cancer spreading to the lymph nodes.
Thank you. Was there a time when an invasive procedure was discussed and undertaken?
Yes, for Ms. Schertzinger, they had also been concerned, in addition to that which I've already described, that she had some lesions that appeared within her liver. And they weren't sure whether this represented spread of the cancer from the lung to her liver, or if it was just a secondary, unrelated problem. So they had worked her up and decided that rather than attempt to do a focused biopsy of the lung mass, that they would first attempt to biopsy the liver lesions, and that they would do that in interventional radiology. So rather than take her to the operating room and open her up and look at the liver, it can be done under imaging in the radiology department, where they'll pass a needle with the guidance of CT and thereby get tissue. And she did undergo that procedure, but unfortunately, post-operatively, she appeared to experience bleeding, which is not inherently uncommon, because the liver has a lot of blood flow. So when you go in to do a biopsy, that is a known risk that could occur. And as a result of the bleeding, she developed some blood in her abdominal compartment, thought likely due to bleeding from the liver, and she dropped the blood counts as well, which then resulted in her blood pressure deteriorating.
Thank you. At some point, did she go code?
Correct. So the initial hope of the treatment team was that by giving her fluids and possible blood transfusions, that the bleeding on the liver would slow down and she would stabilize. But unfortunately, then what intervened was that she did suffer what's known as a code blue and require resuscitation.
I'm going to place page 18 of your report. There's a comments section about the code. It was indicated patient in PEA. What is that?
So the initials PEA stands for Pulseless Electrical Activity. And what that means in common parlance means that when you look at the EKG, there's still electrical activity on the monitor, so it's not flatline. But when you try to feel a pulse of the patient, there's no pulse. So there's basically a disconnection between the electrical activity of the heart and the heart's ability to beat. And that's usually not directly related to the heart. It means that something else is causing it. And very commonly, it's a cause of bleeding, hemorrhage, shock, or an acute change in the respiratory status. So if you can determine what the cause of the PA is, often you can resuscitate the patient and restore the function of the heart.
Was that determined in this case?
Yes, the cause of her PA appeared to be the bleeding in her belly, which was the hemoperitoneum as a result of the liver biopsy.
And this indicates that she was transferred to the intensive care unit, placed on vasopressors, and an arterial line was placed.
Correct. So she had CPR, she had the breathing tube placed, And then, not unexpectedly, because of the low blood pressure, she was placed on the vasopressors to support her blood pressure. And then they placed both a central line, meaning that they put a big catheter in one of the major blood vessels in order to give her the vasopressors and inotropes. And they also placed an arterial line to draw arterial blood gases and to measure continuously the blood pressure. So as opposed to the cuff, which goes up every 3 minutes or 5 minutes, the arterial line is hooked up into the monitor, so every second you see the blood pressure.
Thank you. Was the code status for this lady eventually changed?
It was, yes.
Okay. And at some point after the code status change, did Dr. Hussell order medication for an extubation?
Yes, correct. So again, the code status was changed, I believe, on October the 9th. October the 9th of 2017. And then thereafter, there were orders placed for the administration of 500 mics of fentanyl at 11:22 p.m. on October the 9th, and then at the same time, Versed or midazolam 4 milligrams.
Thank you. At the time that the Versed and midazolam, or the fentanyl and midazolam were ordered, had there been any paralytics administered to this patient? I can offer the NAR if you'd like to see it, Doctor.
Yes, may I see the medical admission record?
Of course. In this patient, the MAR is found at page 822 to 862.
Thank you. So I actually, in the MARS, don't see an entry for there, but in my report, I indicate at the time the patient was intubated, the patient was given 200 milligrams of succinylcholine, although I don't see that entered in the MARS.
Okay, where would that have come up in your report?
That was on page 19.
And how do you want to handle that? Do you want to withdraw that as a comment in your report? Or would you like the opportunity over the lunch hour to maybe review more the full medical record?
Okay, is that a question?
I'm asking. It is a question, Your Honor.
No, it's not. You're giving choices, sustained.
Okay. Would you then like to, how would you like to handle that, Your Honor?
Sustained.
Yeah, so
Okay, there's no question
There's no
pending.
question. Doctor, do you have any explanation for why that appears in your report and not in the medical record?
I believe that to be an error in terms of the entry specifically regarding on page 24, the reference to cisatracure and mervecuronium.
Okay, so do you want to, do we then assume that you want to delete that?
Correct.
Objection, Your Honor, as to giving her options as to how to
Yeah,
use this in the report.
I agree. The jury can make whatever determination they want. They're the ones judging the credibility of the witness.
Thank you. Have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
Yes, at the time that I wrote the report, I did review the medication.
And I'm relating...
Wait, I'm sorry. Sorry, what was the question? Sorry. Could I ask for the court reporter to read it back? With permission from the court?
You may.
I'll withdraw it.
Well,
Yeah. There was an answer, so I just want to make sure I'm hearing the question right.
let's read it back.
Question, have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
That was asked and answered, Your Honor. The witness indicated he had reviewed the medical records in each and every one of these cases, which included the MARS.
Okay, thank you, Your Honor.
So I move to strike the question and the answer.
You be so strict and disregard the question and answer since he previously answered it.
Thank you. What medications were administered to Ms. Schertzinger at the point of her biopsy?
May I review the MARS one more time? Thank you. So it appeared in the afternoon at around the time of the biopsy, the patient had been given the medication tramadol, which is an oral pain medication, 50 milligrams. That was received at 2:39 p.m. And then approximately 18 minutes later, the patient was given 0.5 milligrams of Dilaudid. And then the patient received a second dose of Dilaudid, or at least a second dose was ordered at 15:12, although at that point the action details again seem to attribute that to the former involvement of the medication that was described earlier.
Thank you.
Pain score? Which one?
See it posted? Did you review the pain scores?
Yes, ma'am, I did.
Is that what those are?
Yes, so this document is what's called as the direct charting flow sheet that has the pain score starting on October 3rd, 2017, up through the October 9th, 2017 the date of the death. And then below that, there is the category that's called is pain level acceptable, charting for the same period of time. And then on the subsequent pages is listed what form of a pain scale was used in order to document the pain. And then the document will also indicates where the location of the pain was, which in Ms. Schertzinger, it was identified as being essentially back pain.
Thank you. What is your opinion with regard to whether or not Ms. Schertzinger had a salvageable medical condition?
In my professional opinion, within a reasonable degree of medical probability, Ms. Schertzinger most definitely had a salvageable medical condition, given that the abrupt nature of her deterioration was immediately following the liver biopsy, which was done in intervention radiology, and had resulted in a diagnosis that we often treat, which is hemorrhage into the abdomen and anemia. That should first have been addressed to make sure that she was appropriately resuscitated from that. And then, of course, subsequently, once the hemorrhagic shock and hemodynamic instability from that was corrected, then later on attention would have been placed to treat the underlying lung cancer, the bronchogenic carcinoma. But had I been Mrs. Schertzinger's physician, I would have counseled her family that she likely had a life expectancy of approximately a year with appropriate treatment. So again, there was not an immediate possibility of death based on the lung cancer. Again, there were treatment options that she could have been referred to. It was just the abruptness of the liver issue and the subsequent bleeding that caused her condition to rapidly deteriorate.
Did Dr. Hussel proceed to order extubation in this case?
Yes, although there was no formal order for extubation, yes, he did order it, and the process of terminal extubation was undertaken.
Thank you. What level of dosing was chosen for this patient?
So in terms of the order that was placed, Dr. Hussel ordered on October the 9th in the evening 500 micrograms of fentanyl, in addition to 4 milligrams of Versed to be given to the patient.
Thank you. Is there any legitimate medical reason for this dose or combination dose of fentanyl and Versed?
In my professional opinion, again, within a reasonable degree of medical certainty, given the fact that she just earlier that day had suffered significant bleeding from the liver biopsy and deterioration from hemorrhagic shock, there is no indication to give fentanyl at this level of dosage, nor to give the Versed, particularly since even prior to the biopsy, the vast majority of her pain scores were very, very low or non-existent. There would be no clinical reason to give these dosing, particularly since she had required the addition of both Levophed, the vasopressor, and epinephrine, adrenaline, to resuscitate her after the code blue. Then more likely than not, these medications would have a deleterious effect on her ability to sustain respiration moving forward.
Thank you. In your opinion, did the dosing of the fentanyl and Versed hasten and/or cause her death?
Yes, in my professional opinion, the administration of fentanyl at this dose, 500 micrograms, coupled with the simultaneous administration of the Versed at 4 milligrams, given her medical history, which included the lung pathology, which was the lung cancer, and the events that I described earlier regarding the liver biopsy, the bleeding, the shock, and the code blue, most definitely did hasten Ms. Schertzinger's death on the evening of October the 9th.
Thank you. In your opinion, does the doctrine of double effect have appropriate application in the matter of Ms. Schertzinger?
In my opinion, the doctrine of double effect is not applicable to Ms. Schertzinger because, again, there was no attempt at appropriate moderation, meaning giving the patient medications at a lower dose, or at proportionality, meaning to essentially try to support her and resuscitate her from the hemorrhagic shock that led to the cardiac arrest, and then see whether or not she could be stabilized and from there come out. At a later date then to discuss with her or her family what treatment could be offered for the lung cancer. So again, in this case, the orders for the fentanyl and Versed were excessive and out of proportion with what she had needed prior to that or would need for terminal extubation. So again, it would, in my opinion, professionally be a violation of the doctrine of double effect because the risks would greatly outweigh the benefits.
Thank you, Doctor. What actions or lack of actions taken by Dr. Hussel speak to his intent in this matter?
So first of all, I believe the hasty decision to proceed with terminal extubation and withdrawal of support that evening when she just recently had had the deterioration speaks to intent. Again, secondly, the failure to involve palliative care medicine because this is a case where, based on the high likelihood of the bronchogenic carcinoma, there would have to be a discussion about what end-of-life decisions would need to be made. And again, many of these patients can be stabilized and be then eventually discharged to hospice, whether that's home hospice or inpatient hospice, so that option should be given. And then again, a really detailed explanation of the thought process as to why there should be a rapid withdrawal of support, given that her deterioration had occurred simply on that day.
And what is your opinion insofar as his intent?
In this case, based on the totality of the evidence in the medical record, it appears that the intent of Dr. Hussel was to hasten the patient's death by the administration of the fentanyl 500 mics, the Versed 4 milligrams, and then the progression to terminal extubation with then the withdrawal of life support.
Thank you. Mayor.
Let's move on, and then we'll come back.
Okay, thank you. Thank you. We're now going to move on to the matter of Danny Millette, which I believe is count 4. Thank you. Doctor, what is the presenting problem with Mr. Millette?
So in Mr. Millette, he had been transferred to Mount Carmel West with an acute change in his mental status. Of importance is the fact that he had underlying significant peripheral vascular disease that affected his legs. So he had developed in the preceding period of time a gangrene of his right great toe, and that had been amputated. So he had been in the hospital and had then been, once stabilized, he was transferred to what's known as an extended care facility for essentially continued treatment of the possible infection and blood flow problems of his lower extremity, as well as to try to strengthen him. But while there, he had this abrupt change that the wife found him unresponsive, and as a result, he was then transferred to Mount Carmel West for evaluation.
And doctor, did you review Mr. Millette's medical record in this matter?
Yes, ma'am, I did.
Thank you. How many days was Mr. Millette in the hospital?
Mr. Millette was essentially in the hospital. He was brought in on December the 5th, and then he was terminally extubated later that night. So in regards to his final admission, it appears he only had 1 day of hospitalization.
Okay, thank you. And what occurred during that hospitalization?
So unfortunately for Mr. Millett, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Doctor, stop a
Let's
minute.
hold on for 1 second.
I actually don't think I touched anything. Any clue as to
Well, I'm trying.
what I should do?
There we are.
Thank you. Sorry. Could you read back the last question and response before the flashing?
Question, what occurred during that hospitalization? Answer, so unfortunately for Mr. Millett, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring of resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Thank you. Doctor, do you have an opinion as to the scope of his medical problems?
Yes, I have an opinion regarding the scope of his medical problems.
And do you feel that, given the scope of his medical problems, that he had a salvageable situation?
Yes, certainly Mr. Millett was critically ill. He had multiple medical problems that justified admission to the intensive care unit. But again, given the circumstances that there was an identifiable cause and that the cardiologist who was brought in on the case felt that this was not a primary heart problem, but rather secondary to another problem, which in this case was the infection that would have been contained in his lower extremity. And he had suffered abnormal blood chemistries and acid-base disturbances. Certainly he warranted ongoing resuscitation to see whether or not his conditions could be stabilized, and the multi-organ dysfunction that was determined by the ICU doctor, Dr. Duffy, could in fact be reversed.
Thank you. Did you find indication in the record that this gentleman was experiencing pain or distress?
No, in fact, the opposite. In reviewing his record, and likely because of not only the suddenness, but the numerous cardiopulmonary arrests, Mr. Millett was definitely in a coma. So I would describe him as comatose, and there was no indication that he was demonstrating any form of pain or suffering at the time that he was brought into the emergency room or the ICU.
I'm going to present pain scoring to him. I'm going to present Mr. Millett's pain score information, which appears at 342 to 348 in the MAR. What do you find there, doctor?
What I find is consistent with my prior answer, that Mr. Millett was documented to have a 0 on the pain score. The nurses that cared for him during the day did not find any indication of pain. Also, his Glasgow coma scale was a 3, the lowest it could be, meaning he was, in fact, comatose. And at the time that he was examined, his pupils were non-reactive. They were 5/5. So again, all of those findings are consistent with a patient who remains in coma. And it was not until the evening of December 5th that there was one entry by a nurse that corresponded with the administration of the medications for terminal extubation, where he was given a 10 on the pain scale. But everything preceding that was a 0.
Doctor, do you feel that this extubation was appropriate?
In my professional opinion, it is my opinion that this extubation at this point in his care was not appropriate, since all appropriate resuscitation measures had not yet been exhausted.
What dosages were offered to him at the point of extubation?
So Mr. Millett was ordered and then received 1,000 micrograms of fentanyl. He received 4 milligrams of Versed, and he also received 2 milligrams of Dilaudid.
Thank you. Was there any legitimate medical reason for these dosages?
In my professional opinion, expressed within a reasonable degree of medical certainty, given that Mr. Millett was clearly comatose, that he had no reaction to either physicians or nurses that day who had examined him, that his pain scale had been a 0, that he had a Glasgow coma scale of 3, that he was basically demonstrating by all manners of diagnostic ability a coma and comatose, I can think of no medical justification for administering these 3 medications at the dosages that were prescribed by Dr. Hussel.
What purpose could this dosing serve at this level?
There certainly would be no medical justification of giving a patient 2 opioid medications when they were in coma and they were not experiencing or documenting pain. Similarly, if a patient is in coma, it would be impossible to assess whether or not the patient had anxiety or fear. So a sedative hypnotic when you're already in a coma is not medically justified. So the only plausible explanation for administering fentanyl, Dilaudid, and morphine would be to hasten the patient's death by interfering with their ability to breathe spontaneously once the breathing tube is removed and the patient is taken off of life support.
In your opinion, did the dosing in this case hasten and/or cause his death?
Yes, in my professional opinion, the administration of 1,000 micrograms of fentanyl coupled with the Versed and the Dilaudid rapidly served to depress Mr. Millett's respiration, and then the concomitant removal of the breathing tube and life support then accelerated his death because he could no longer breathe, particularly given that he had had all those attempts at resuscitation earlier in the day.
In your opinion, does the doctrine of double effect have application in this case?
No. In review of Mr. Millett's record, the doctrine of double effect is not, again, applicable because, first of all, he had not, or the doctors had not exhausted the maximum medical therapy to see whether or not his condition was reversible. And equally important, had not given Mr. Millett enough time to declare whether the underlying conditions themselves were terminal and care was futile. Secondly, since there was no medical justification for giving 2 powerful opioid medications in a patient who previously was clearly in coma and unconscious, the doctrine of double effect would not support then giving these medications because, again, it shows no moderation, there's no reduction in dosing, and it's out of proportion what the patient himself would need for any reasonable or prudent decision to try to avoid pain on terminal extubation, which, again, generally is not painful. And lastly, the administration of Versed in combination with the opioids would more likely than not result in respiratory depression, which again in this situation would not be supported by doctrine of double effect because it would overweigh the risks, that being respiratory depression, versus any potential benefit.
Do you feel that this procedure was an emergent procedure?
No, in studying Dr. Duffy, one of the pulmonary critical care's progress notes, it was clear that a well-established plan of how to support Mr. Millett was entered into the medical record, and they were planning to support him on the ventilator with the current vasopressors and see whether his underlying metabolic condition could be corrected and that he would be reevaluated the next day to then have a multidisciplinary discussion with the family on whether or not life support should be withdrawn. So to move hastily in the middle of the evening to terminally extubate and withdraw support would seem to have no medical justification when the team that had performed the comprehensive critical care admission had clearly laid out the plan in the medical record.
Thank you. What actions or lack of action by Dr. Hussell speak to his intent in this matter?
So, first of all, the lack of definitive communication with the admitting and critical care consulting team who had initially evaluated him and had established the plan, and the need for reevaluation on the subsequent day shows intent. Secondly, the failure to obtain appropriate consultation with palliative care, even if that consultation would occur on the next day when there was the plan to talk about the chances of a survivability. The decision to order 2 powerful opioid medications when Mr. Millett was not demonstrating any pain. The addition of the Versed when he clearly was a Glasgow Coma Scale of 3 and all his physical findings demonstrated that he was comatose and thus would not be processing any fear or anxiety. And also then the relative hasty decision to proceed with a terminal extubation in the middle of the night when more likely than not it would result in his rapid death all speaks to the intention of Dr. Hussell in ordering these 3 medications at the specific dosages they were ordered.
What do you believe the intention was in this case?
In my professional opinion, having studied Mr. Millett's record, the intention was to rapidly terminate Mr. Millett's ability to breathe on his own and thus result in a hastened death after the breathing tube had been removed and life support had been terminated.
Thank you. Dr. Schweiger, let's now turn to the matter of Brandy Mcdonald, which I believe is count 5. What was Ms. McDonald's presenting problem?
So Mrs. McDonald had been diagnosed years earlier with a rare form of ovarian cancer, and that cancer had at the time been found to have spread into her abdomen. So she had undergone a total abdominal hysterectomy and removal of her ovaries, as well as multiple tumor debulkings in order to control the ovarian cancer. She had also been given chemotherapy and had entered approximately a 3+ year period of remission. Unfortunately for Ms. Mcdonald, it appeared the ovarian cancer had returned, so she was enrolled in a new research protocol, and she was given new chemotherapeutic agents, and this is nivolumab, Nivolumab. As a result of that, one of the known side effects is that it can injure the patient's liver. And it is thought that that's what's known as an autoimmune reaction of the chemotherapy on the liver. Autoimmune means the body is sensitized and then sees parts of itself as foreign and attacks it. So there was concern that she was having a liver injury, and thus she was brought to the hospital both to work up the status of her liver, but also to evaluate the remainder of her organs, given that she had some additional medical problems.
Thank you. And doctor, did you review her full medical record?
I did, yes, ma'am.
I'm going to present to you State's Exhibit 32G and direct your attention to the overview comment. On the front page. Is there a typographical error?
Yes. As one would note, I think I used the template, and there is a typographical error. It lists Francis Burke, but again, this is the report for Brandy McDonald, so that was just a typographical error.
Thank you. And is Brandy McDonald's name listed 3 times at the top of the report?
Yes, it's listed 3 times at the top of the report, above where I made the typo, and then on each successive page, it's listed at the top of the report on each of the pages of the report.
Okay, thank you. So, what was Ms. McDonald's course in the hospital?
So initially, when she was brought in, again, the concern was regarding her liver and the fact that she had elevated liver enzymes. And as I noted on page 3 of my report, she was actually a full code, that she wanted resuscitation and she wanted to be supported through that process. As she went through the process, however, she did demonstrate instability, and she had a worsening respiratory component to the point where on January the 14th of 2018, the patient appeared to have a cardiopulmonary decompensation and arrest and required Dr. Hussel to place an endotracheal tube and put her on the ventilator. And he had administered 2 milligrams of Versed and 200 milligrams of succinylcholine and was able to successfully intubate the patient. Because there was concern about autoimmune hepatitis, the decision of her treatment team was then to administer high-dose steroids to try to reduce the inflammation in her liver, and that was then undertaken throughout the hospitalization, and she was then going to be started on prednisone 120 milligrams through that. Her serum lactate did increase, as well as her liver enzymes. And at one point, they did send her down for a study because there was concern that she might have emboli in her lungs, what's known as pulmonary emboli. And that was confirmed that she had bilateral pulmonary emboli. And then eventually, she had been on a medication that is used for a lot of people that have type 2 diabetes. It's called metformin. And that medication, oral hypoglycemia, can result in acidosis if the body goes into shock or other problems occur. So she developed a worsening metabolic acidosis, and it was thought that it was likely contributed to by the metformin. So she was then placed on essentially continuous dialysis in order both to control her volume status, but also the dialysis machine could purify the blood and correct the underlying metabolic acidosis.
Thank you. As you review her situation, do you feel that she had a salvageable medical condition?
Yes, within a reasonable degree of medical probability in the short term, which is related to this hospitalization and the impact that the toxicity of the chemotherapy had on her liver, and the fact there also appeared to be impact of the metformin. Clearly, there would have been salvageability to have stabilized her medical condition and, again, allow her to get into a position where then discussions could have been had with her and her family about eventual wishes regarding either home hospice or inpatient hospice. Again, clearly in terms of her underlying ovarian cancer and the metastases, that did paint a difficult situation in the next couple of weeks or months. So certainly that needed to be discussed. But in terms of what actually brought her to Mount Carmel on January 11th of 2018, and then the decompensation, those were all issues that are routinely treated by critical care teams in an ICU.
Was she appropriately placed in the ICU?
Yes, given, first of all, the complexity of her medical problems and the fact that she had been undergoing chemotherapy, those are high-risk patients. Their immune system is impaired. They can easily get infections, so they warrant admission to the ICU, both for surveillance and then for potential treatment. Also, her body habitus, even though that she had undergone the abdominal surgery in the past, she was morbidly obese, and so that also factors in that she benefited from careful observation and treatment. And then, of course, because both her liver and then her kidney were showing signs of deterioration, it was justifiable to have her in the intensive care unit for ongoing treatment.
Was intubation appropriate?
Yes, at the time that Dr. Hussel evaluated her, I most definitely support his decision to intubate her. She needed to have, at that point, the tube. Not only was there evidence of multi-organ dysfunction, but as I mentioned earlier, there was this issue about the multiple pulmonary emboli, which again needed support in treatment. So as a temporizing measure, and as a measure to provide supportive mechanical ventilation, I definitely support the decision to intubate her.
If she had been your patient, how would you undertake her case?
Had Ms. Mcdonald been entrusted into my care, I would have convened a multidisciplinary panel, most notably with her oncologist who had been guiding her chemotherapy, to fully understand what the prognosis of this ovarian cancer that had had recurrence was, and what the likelihood of this new, essentially, treatment protocol could offer her. Because again, as a critical care doctor, we deal with cancer patients, but we do not administer or manage chemotherapy. So that is really outside of our area of specialty. So we need to get input from the oncologist in terms of both the life expectancy related to this cancer, as well as the treatment, which again, in this case, was advanced. This was specialized treatment. Additionally, getting input from gastroenterology regarding the liver and whether or not the liver could rebound with response to the steroids, and then input from the kidney doctors about the effect of the dialysis would all have been very, very important. So this is the type of patient, given her youth, the fact that she had a relatively young child, and that she had expressed desire for full resuscitation, that I would convene such a conference and have a deep drill down into her medical situation. Obviously, ultimately, the critical care would orchestrate that. I, as mentioned, would also include in those discussions the palliative care team, because it would be important not only to address the short-term prognosis, but then her desire for long-term issues, both in regard to palliative care as well as potential long-term issues of hospice in that setting. And then, of course, I would have continued to support her for several days to see whether her organs showed improvement. If the liver and the kidney continued to show further deterioration and/or her heart and lungs continued to show deterioration, certainly I would have discussed potential palliative care later on, but at the time the decision was made, I believe it was too hasty to conclude that there was no hope for her treatment or support.
Thank you. At some point, was there discussion of going to a DNRCC?
Correct, yes. So then eventually there was an order placed in the chart on January the 14th at 10:13 in the evening to change her status from full resuscitation measures over to DNR comfort care.
Pain scoring for Brandy. Did you review the pain scoring in this case?
Yes, ma'am, I did.
And for the record, the pain score on Ms. Mcdonald is found at page 288 in the medical record.
Thank you.
Thank you. What does the pain scoring reveal?
So from the date of her admission on January the 11th through January 14th, she had a pain score of 0. She had no pain whatsoever described by the nursing staff. Then on the early evening, I believe of January 14th, there is one entry that she had of an 8. And then that followed a 0. What followed was a 0. And then at the time that the palliative care medications were administered, she had a score of 10.
Thank you. Have you reviewed the medications given to this patient while hospitalized?
I have, yes, ma'am.
Thank you. Is there any legitimate reason for the dosing that was offered to and administered to this patient at the point of her extubation?
No, in my professional opinion, based on the review of her medical records, as well as the fact that she had abnormal liver function and was requiring dialysis and had the underlying problems of her lung, I can think of no justification for the orders that were placed at the time of the terminal extubation. Also, I might just add that earlier that day on January the 14th, there was an order placed by Dr. Hussel for fentanyl 50 mics IV every hour, PRN, meaning as needed. Certainly, I am not in any way critical of that order. That was showing a judicious, small, incremental dose that the nurses could have given her if, in fact, that she needed it for pain. So I was puzzled when then later that night I saw that the order for fentanyl at the time of extubation was 20 times that. So rather than 50, which was ordered in the morning, she was then ordered 1,000 micrograms of fentanyl.
Thank you. Who ordered the 50?
Dr. Husel ordered the 50.
Okay. What purpose could this dosing at point of extubation serve?
Well, given that Ms. Mcdonald had little complaints or objective documentation of pain, other than, as I said, the one entry of an 8, the only plausible explanation that I could come up with as to why an order for 1,000 micrograms of fentanyl would be given would be the intent to hasten the patient's respiratory compromise and thus result in apnea, which would accelerate the patient's death after the terminal extubation and the withdrawal of support.
In your opinion, did the dosing at these levels hasten and/or cause her death?
Yes, within a reasonable degree of medical certainty, particularly in review of the medical admission record of prior administration of any form of medications, as well as the order that I mentioned had been placed in the early morning hours of January 14th for the 50 micrograms Q1 hour. I believe that, in fact, the administration of 1,000 micrograms of fentanyl coupled with the administration of the 6 milligrams of Versed did hasten Ms. Mcdonald's death after the breathing tube was removed.
In your opinion, does the doctrine of double effect have application in this case?
No, in studying Mrs. McDonald's case, I could not see justification for the doctrine of double effect. Here again, this was a young patient with a young daughter, or young child at least, who had expressed a desire for full resuscitation and had pursued as an outpatient every form of aggressive treatment to try to manage her ovarian cancer and metastases. The fact that she had a known side effect of one of these new experimental anti-cancer drugs would not then invoke the doctrine of double effect, because again, one would want to first give a moderate attempt at management of the patient and proportionally respond. Again, by giving her such an increase in narcotic dose, the 1,000 micrograms, coupled with the 6 milligrams Versed, at the time that her liver was acutely inflamed and not working, it would not be able to handle these medications or metabolize them in any way close to normal. So there would be a prolonged excessive impact of those. So that would violate any application of the doctrine of double effect. And the fact that she had the underlying deterioration in her lung, as well as the fact she was morbidly obese, more likely than not, removing the breathing tube would result in her being unable to breathe. So again, that would violate the rule of moderation or proportionality.
Thank you. What actions or lack of action by Dr. Hussel speak to his intent in this matter?
So certainly, in terms of the action, the decision to place an order for fentanyl at 20 times the dose of the prior order would speak to the intent that one was specifically trying to cause apnea and terminate the patient's breathing. Again, especially in the background of the pain scores. Also, the decision to add Versed into the decision, given the fact that she had the liver dysfunction, the renal abnormalities, the pulmonary emboli, would heighten the impact of the fentanyl, because the two of them together would make it more likely that the patient would not breathe and would thus go apneic, and given her limited reserve, would rapidly progress to death. And then again, the lack of action, meaning the failure to convene a multidisciplinary conference, having never discussed her condition with the oncologist who was managing her cancer, not talking to the GI doctors or kidney doctors who had provided support at Mount Carmel to try to temporize her. Those all speak to the intent of the individual placing these orders.
What do you believe that intent was?
In my professional opinion, the intent in this case was to hasten the demise of the patient once the breathing tube was removed, and thus, more likely than not, within a reasonable degree of medical certainty, rapidly result in the death of the patient.
Thank you. Your Honor.
You finished with that?
Do you want to address that one issue with Scherzinger, or do you want to do that after lunch?
We can do that after lunch.
Okay.
We need to circle back on a previous patient, but if the
Let's do
court
that
is
after lunch, ladies
ready
and
to do
gentlemen. Let's come back at 5 after 1. That gives you an hour. You guys have a wonderful lunch. Remember the admonitions. With that, Mr. Phillips?
All rise.
Have a great lunch, guys. There's probably leftover pulled pork from what I hear. Okay, you may step down. Remember the admonition before? Let's let him get out of the room.
Yes, Your Honor.
Okay, Ms. Grubb, you there? Okay.
Sorry, Your Honor.
First things first, I know we have some subjects we need to talk about. Anything for the record so far?
I don't believe so, Your Honor.
Ms. Menashe? Okay, Mr. Zion, it's my understanding you wanted to discuss the subject matter?
Yes, Your Honor. It was my understanding at the sidebar that the court determined that it would be inappropriate for us to try to adduce evidence as to the defendant's state of mind regarding recklessness. Just referring back to, we did solicit that information on the record from Dr. Ely. We believe that this is an appropriate subject for to be explored upon, not with fact witnesses, but with Dr. Ely and with our other expert witness, now Dr. Schweiger. The court did have a motion in limine ahead of time stating that whether or not an instruction on reckless would depend on facts adduced at trial. This is the witness to do it with. This is one of two witnesses we intend to do it with at trial. So we would request the opportunity to ask this witness those questions, if not a purposeful act on part of the defendant. Is it at least reckless in your opinion? So that's why we're asking, that's why we would ask the commission to do that with this witness, at this time.
But he's testified it's always been a purposeful act.
Correct, Your Honor. And so we would ask that, that reckless being a lesser mens rea purpose, would this at least be a reckless act? So we would ask that that be allowed to be asked.
But if all the evidence is shown purposely, if all the evidence is shown purposely,
Yes, sir.
why do you even give a lesser, since you basically are directed at that? That's how he was indicted. There's no reason to even address it because technically you don't even get the lesser.
Well, I think we get any lessers that are part of the greater offense if there's evidence of it at a trial. And so I think it is a reasonable thing to ask a witness, an expert witness in this case, who's you've given permission and find it appropriate to opine on a person's mens rea. If this is not, in your opinion, a purposeful act, a specific intention to cause their death, would you say that it at least is a reckless act? So, which is a lesser mens rea, and reckless is a lesser of purposeful homicide. We never indict lessers, unless it is the charged offense. And so we did not in this case, Your Honor. But we believe it is an appropriate lesser to instruct should evidence be adduced at trial. This is the witness, along with Dr. Ely, who's already testified, who did testify that in his opinion, if it wasn't purposeful, it was at least reckless. And that's all we're asking for.
Response?
Your Honor, it's my understanding, having read the reports, that this expert is going to say that with a reasonable degree of medical certainty and in his expert opinion that the intentions of Dr. Husel were to hasten the death. So the question of, in the alternative, if you don't think it was purposeful, do you think it was reckless, is an irrelevant question, and I would object to it, because the testimony is he believes that the intent is purpose, to hasten. He said that today, as with respect to all 5 patients that we've gone through so far, and he says that in every one of his 14 reports. So we don't get to the reckless or the questioning of, but for purpose, do you find reckless?
Any comment on the trial court's obligation in giving a lesser?
Yes, Your Honor. I think this case has been pending for 3+ years. I don't have the exact math. I do not believe that the law is that the court must give a lesser if a lesser exists under the Ohio Revised Code. I think if it is certainly, first of all, it's up to the judge to determine whether the evidence supports it. But it's not, we're afraid that we're going to lose as we've indicted, and so now we get a lesser. They've presented evidence and indicted a case on purpose with having to prove causation as well. That's the case that we've prepped, that's the case that we've readied for, and as this court knows, and we've certainly litigated this issue, it wasn't until this newer set of prosecutors were on the case that we even received an email about their intention to ask for a lesser. Truly, that had never been discussed in the 2+ years, because had it been, we would have litigated the issue of immunity earlier. Also, Judge, you know best. You've been in this county for a very long time, and I've certainly done a lot of cases here. To say that this county does not indict on lessers is an inaccurate statement. They've had all this time to amend the indictment.
Okay.
Represent it to a grand
Anything
jury.
else?
Judge, I've been here 24 years. Now, I know that is about probably half of what you've done, but we don't indict lessers. So I've done this job for 24 years. And with Jimmy and Ron, I did it for 23 of those years. So I am very much aware of how we indict. Any party can request a lesser if there's evidence of it. We're just asking for the opportunity to solicit that evidence from this witness, as we did with Dr. Ely, which is appropriate. The only reason we even talked about that lesser ahead of time was I was shocked by Ms. Menashe's assertion during a conversation we had, the one and only pretrial conversation we had about this in the summer, was that it was her assertion that because of the immunity statute, we would be barred from asking for any lessers, including reckless. She said, I understand that, but it's just the way the law is. And I was dumbfounded by her assertion during that conversation that there are no lessers in this case. I researched it, I had appeals research it, and they said, we don't know why you would not get a lesser in this case. And so I brought it up in the email ahead of time. Normally we don't discuss lessers until the close of evidence. And once again, it's both sides can ask. It's not like a defense thing. It's prosecutors can ask for lessers too, should the evidence warrant it. So I brought it up in an email because I thought it might be germane to voir dire and perhaps even opening. And so that's the only reason I brought it to the court's attention. So that's where we're at on it, Judge. We're at that point where we are asking permission to ask what we believe is a very relevant question, the defendant's state of mind. It'd be the lesser state of mind. If it's not purposeful, is it at least reckless? Which I think is a perfectly acceptable question to ask this expert, as we did with Dr. Ely, who answered in the affirmative. Thank you.
Okay, well, just for the record, the simple asking still does not stop the court from going through the analysis they have to do.
Absolutely.
In order to put it there.
Right.
And the things I have, and that's what I'm basing my decision so far. I don't think it's relevant to this. I think everything is for the murder, and that's where we're at. So you made your record. We can go accordingly. The second issue, and I didn't really get a thing because we were kind of rushed, was about the leading questions. State of Ohio versus, and I'll spell it for you, D'Ambrosio, D''Ambrosio. Okay, 67, Ohio State 3rd, 185. Most of the questions haven't been leading. Even though they elicit a yes or no answer, it doesn't necessarily meet the suggestion aspect required there. I adopted for part of 611, C is that except as may be necessary to develop testimony, that's the usual transition between subject matters, summation, those types of things that are traditional things. I may have said transition. Most of the time they weren't leading questions, but I figured it was better for me to say I'll permit a transition so I didn't look like one side or the other was wasting objections. But that was the whole thing. We can go through the analysis as we go, but just a simple yes or no question does not make it leading. It has to be suggestive into the answer. And saying, did you review the records? Yes. That is not a leading question. So I made my record there. Anything on the issue?
Not from the state. Thank you, Your Honor.
No, Your Honor.
Okay. Anything else for the good of the order?
No, Your Honor. Thank you.
Okay. We're on recess till 1:05.